We'll move on to our next presentation with Dr. Lawrence, who will be discussing Celiac Plexus Radiosurgery for pain management and advanced cancer, an international phase 2 trial. Dr. Lawrence?
Hi, good afternoon. On behalf of my co-authors, I should like to thank the scientific committee for selecting our abstract for presentation. These are my disclosures, none of which are relevant. So pancreatic cancer is characterized by a particular retroperitoneal nerve syndrome of epigastric pain that radiates to the lower back. This pain is often severe, debilitating, and difficult to treat. The pain is thought to be caused by infiltration or pressure upon the celiac nerve plexus, which lies immediately posterior to the pancreas itself. One standard treatment which is tried in these patients is what's called a celiac block or celiac neurolysis, in which either local anesthetic or sclerosing agent is injected around the nerve, either via the back or via the esophagus. This is an invasive procedure with acute side effects, and efficacy is limited. And one reason why the efficacy may be limited is actually the celiac plexus is a large structure and actually can only infiltrate a small proportion of the nerve. We hypothesized that radiosurgery targeted to the celiac plexus would be both efficacious with limited side effects. A number of years ago, we developed a technique where we delivered a single fraction of 25 gray to the celiac plexus. You can't actually see this nerve plexus on imaging, so we use the abdominal aorta as a surrogate marker. In addition, the small bowel can be nearby, and we developed a dose painting technique to respect constraints. And here we can see a picture of a typical plan. We did a pilot study at my institution that was recently published in the Red Journal by Yaacov, who today is in Michigan, and we saw good results with limited side effects, but it was only 20 patients. Based upon these positive results, we were fortunate to receive funding to run an international multi-center phase 2 study, and that's the study I'm going to present today for the first time. These are our key eligibility criteria. Adult patients with good performance status who had a typical retroperitoneal pain syndrome. They needed to have severe pain on a 0 to 10 scale, at least 5 out of 10, despite use of analgesics. Regarding the disease, they need to have either pancreatic cancer or any other cancer that infiltrates around the celiac blood vessels. Exclusion criteria were previous use of radiation therapy to the upper abdomen or poor life expectancy. The primary endpoint was the complete or partial pain response at 3 weeks, and here you have the precise definition on the screen. Our primary instrument we used was the BPI, the Brief Pain Inventory, and here you can see on the screen what that looks like. In terms of power calculation, we stated that the procedure would be justified if we can show at least 40% of patients have a successful outcome. And based upon that, we calculated you need a total of 90 evaluable patients would be required to have a 97% chance of demonstrating this on a one-sided statistical significance of 2.5%. So we put together a consortium, which ultimately consisted of 8 medical centers across 3 continents, 3 in North America, 2 in Europe, and 3 in Israel. The trial accrued over 4 years, and we closed to accrual in January of this year. It's not trivial to radiate the celiac plexus due to the presence of bowel, and so we created a robust quality assurance procedures, including educational materials, a benchmark dummy test that was mandatory, and rapid review of the first 3 plans from each subsite. The protocol itself has already been published by Gali Jacobson, who today is in MD Anderson, and that's available, and likewise there are a number of YouTube educational videos which you're welcome to watch. This is the schema. So at informed consent, there was a brief assessment, and then there was a more comprehensive assessment at 3 and 6 weeks post-treatment. So moving on to results. So this is our consort diagram. 149 patients were accrued, of which 125 received treatment, and of 19 were deemed to be evaluable. The definition of evaluable patients were predefined within the protocol, and briefly we excluded patients who had unstable pain syndromes, we excluded patients who were missing baseline data, and we excluded patients who unfortunately died prior to the initial follow-up. These are our baseline characteristics. There was a slight predominance of women. The median age was 65. The vast majority of patients had metastatic pancreatic cancer. These patients were very sick. The median length from diagnosis was 300 days, and almost all had received at least one, if not more, lines of systemic therapy. Their pain level was 6 out of 10 on median, which is severe. And in terms of opioid use, at baseline, they were using on average, or on median, 54.0 milligrams of equivalent of intravenous morphine, and that translates to 100 milligrams of oral oxycodone per day. So very high doses of opioids at baseline. So these are my two most important slides. The primary endpoint of the 90 evaluable patients, 48 were said to have a positive response, and that corresponds to a response rate of 53%, which on statistically is far greater than the 40% that we defined to be a successful study. On a sensitivity analysis, if you exclude the patients who actually didn't report at 3 weeks, the response rate increases to 56%. We can see this visually here. These are water plot graphs. So just to explain, each column here, each line here is one patient, and this is the delta from baseline to 3 weeks or to 6 weeks. You can see the vast majority of patients have negative scores to say that the pain improved. You can note that there is a dotted line at -2, and that's because in the pain literature, an improvement of 2 points is considered to be meaningful. Another way to visualize this is looking at absolute scores, baseline 3 and 6. You can see that the pain seems to improve over time. In terms of opioid use, so at baseline 54 milligrams, it didn't change at 3 weeks, but it dropped by 1/3 by 6 weeks. In terms of use of short-acting opioids for breakthrough pain, so it was 7 times per day at baseline, 5 times a day at 3 weeks, and it dropped to 3 times a day at 6 weeks. All these changes were highly significant. There were minimal adverse events. In terms of severe adverse events, there were just 5 possibly related events, all of which are familiar as symptoms of the cancer itself. So in conclusion, single-shot celiac plexus radiosurgery decreases pain, decreases opioid use, and has minimal side effects. And we consider this a new possible treatment option for cancer pain emanating from the celiac plexus. I should like to acknowledge my co-investigators in the radiation teams. I should acknowledge the substantial financial support we got from Gateway for Cancer Research and some additional support from the Israeli Cancer Association. And finally, but not least, I should like to thank the families and the patients, many of whom agreed to enroll in the study in the twilight periods of their lives. Thank you.
Questions for Dr. Lawrence? Please go to the microphone.
Thank you for such a great presentation. What is a practical suggestion in doing SBRT, SR, or for this patients who often have like intractable pain? It's my patients with pancreas cancer who are so uncomfortable are the ones I can't immobilize or can't keep still. Did you guys have some techniques that you could recommend to us to offer patients like this the therapy?
Yeah, sure. So first of all, we tried to be pragmatic. So we said in the protocol, ideally do 4D and 3D simulations, intravenous contrast, but we appreciated that wasn't always possible. And, it was possible to do a simple simulation, a 3D simulation with all contrast that was good enough. In terms of the time of treatment, we treated at the maximum dose rate possible on a true beam, which I forget what it is, but the FFF mode. And typically we completed treatment within 8 minutes. At my center, we treated over 80, 90 patients, and I don't recall any patients who couldn't complete the treatment.
Thank you.
Other questions for Dr. Lawrence?
Thank you.
Thank you.